So I'm assigned the topic that coronary bypass remains the best therapy for most patients with left main stenosis. And frankly, I think my job is not so hard. These are my disclosures. I think most importantly is that Greg is my friend and colleague, although we don't agree on everything all the time. He did give me this really nice tie, though, which is my personal favorite tie from TCT 2016. I'm wearing it today in his honor. It is a conflict, I guess. It's a very nice tie. So he and I actually had this conversation already 4 years ago. And my assigned topic then was that XL and Noble proved that PCI is still far from an acceptable alternative to coronary bypass for left main revascularization, except for a small proportion of patients. And Greg showed this slide, but there are a couple things that are important to point out. The XL trial was intended to enroll 2,600 and enrolled 1,900 patients and followed them for the initial primary endpoint, a 3-year follow-up, for just a minimum of 2 years, which is far too short to demonstrate differences between coronary bypass and PCI. And I want to demonstrate that many patients were excluded from the XL trial and put in a registry, 2/3 of whom ended up having coronary bypass. So when we extrapolate results from a clinical trial, we have to think about patients who were excluded from that clinical trial, because of course in randomized trials, the bias is at the point of entry, since randomization eliminates bias thereafter. But the bias nonetheless exists at the point of entry, and you can see that 2/3 of patients who were excluded from the XL trial ended up having coronary bypass. That tells you something, and I was struck by the fact that that's a very similar proportion here. This is the coronary bypass. This is the coronary anatomy for the left main group of the Syntax trial. And you notice that 2/3 of the patients in the Syntax trial who had left main disease also had either double or triple vessel disease. I don't think that's a coincidence. Now, in the XL trial, 1.9 lesions were treated per patient with PCI, and there were 2.6 conduits per patient in coronary bypass. So I can't escape the conclusion that we had a more complete revascularization in the CABG group. However, we failed miserably in managing our patients with optimal medical therapy post-op. You can see that a large majority of patients had dual antiplatelet therapy in the PCI group and not in the CABG group. At 3 years in death, stroke, and MI, you can see that there are no significant differences for each of those components of the composite primary endpoint, but that there was a trend in favor of CABG for death. You notice that the MI, of course, is even at 3 years, but that's an important concept that we'll go into a little further. Ischemia-driven repeat revascularization and all repeat revascularization were strongly in favor of coronary bypass. Now, Greg has shown the slides where the two curves cross, and indeed, the biggest deficit for CABG compared to PCI in the left main group occurs in the very first days. And thereafter, from 30 days to 3 years, you can see that death strongly favored CABG with a p-value of 0.02. The composite endpoint favored CABG with an endpoint of p-value of 0.02 and death at p-value of 0.06. And MI strongly favored CABG by about twofold. So I showed this slide in 2017. These were the 3-year data. And I asked the question, which curve would you rather be on? Because there was much heralding of this as showing no difference and that there was a big green light on to do PCI for left main. But again, I ask you, which curve would you rather be on? And what would those curves look like at 5 years? Would they look like this? Is this the future of XL? And I asked myself, what would the difference be at 5 years or 10 years? Because those curves reminded me of this slide that Dr. Fuster gave me from the Freedom trial, where initially in the first 2 to 2.5 years, there was no difference between PCI and DES versus CABG in diabetic patients, but by 5 years, those curves diverged and continued to diverge more widely. And the Syntax trial at 1 and 5 years made the conclusion that CABG should remain the standard of care for patients with complex lesions. And again, I remind you that 2/3 of patients with left main disease also have double or triple coronary disease as well. So this is the Jack paper from 2016, the five-year data from Syntax, concluding that treatment with PCI versus CABG was an independent predictor of cardiac death, and this related to myocardial infarction. Now, in 2019, we, and I mean that literally we, Greg and I and many others, published the 5-year data for the XL trial. As he mentioned, and correctly so, the largest, most definitive trial of CABG in left main, and he deserves a huge amount of credit for getting that across the finish line. But I did have some important concerns about how those data were presented, particularly regarding mortality data, the publication of the pre-specified peri-procedural MI definition, and the statistical analysis at 5 years, which was different than the one we performed at 3 years, switching from a non-inferiority to a superiority analysis. At 5 years, there is an excess and accelerating mortality for PCI. Again, these are relatively low-risk patients with age only 66 and a low to intermediate severity syntax score, but there was a relative increase in risk of 38%, and this was driven by non-procedural MI. Of course, repeat revascularization was also increased, and as Greg did mention, there was no difference in stroke at that point. So some others have taken the liberty of looking at the Excel trial, excluding peri-procedural MI, treating it the way the authors of the Noble trial did, and dealing only with non-procedural MI. And if you do that, then CABG becomes a clear winner for the composite endpoint and for the individual components of death, non-procedural MI, and repeat revascularization. So, the definition of myocardial infarction had a huge role to play in the conclusions reached about the composite primary endpoint. It took over 5 years to reveal the data for the international definition, universal definition of myocardial infarction, demonstrating that for procedural MI by the UDMI, there was actually a preference twofold increase in favor of CABG over PCI, and similarly for all MI, about a twofold increase. So had we presented the data with both definitions, we might have had a different conversation for those first 3 to 5 years about the meaning of XL. Ultimately, Greg and others published this in JACC quite recently, clearly demonstrating that actually the relationship between myocardial infarction and PCI and CABG was about twofold by the SKY definition and about twofold the other way by the UDMI. And again, I think that myocardial infarction is most important because it impacts mortality. Not because the chemical definition has a special meaning, but because it impacts mortality. We counted mortality, and I think that's obviously the most important endpoint. But this kind of understanding, I think, would have produced a more nuanced conversation about left main stenosis. And Greg actually recognized this in a previous publication. This is a state-of-the-art review from 2015 in JACC, arguing that the most frequent and often least clinically relevant components of a composite endpoint tend to be the driver of events, especially enzymatic MIs. And frankly, that's exactly what we did in Excel. So finally, we looked at Excel with a non-inferiority margin at 3 years, a superiority assessment at 5 years. It would not have met the non-inferiority criteria at 5 years. And again, that would have been a different conversation. I'm going to skip through Noble because I see I'm running out of time, and Greg covered it quite well. There was, in fact, a benefit of CABG over PCI from Noble, but not a difference in mortality. But if you take the Excel and Noble trials together, just those two, there's a relative risk in favor of CABG. This is an interesting paper. I don't pretend to be a Bayesian statistician. I read this with interest twice, didn't quite really understand all the mathematics behind it, to be honest, but did recognize the conclusion sentence that Bayesian analysis suggested that whether based on Excel alone or the totality of randomized trials of left main disease, PCI was associated with inferior long-term results for all events, including mortality. So can we do stenting of the left main? Absolutely. Should we in all cases? No. And I actually differ with Greg on just his very first comment, that I don't believe there's a role for CABG, for PCI rather. I really do. I believe we do too much CABG in the elderly and frail people, and I think we do too much PCI in young, healthy people who should have 3 or 4 arterial grafts instead. I think that's where we should be moving as a team, as a heart team. And this is an interesting article from New England Journal in 2005, explaining that the reason CABG beats PCI in many subsets of patients, especially those with complex disease, is because it protects against future myocardial infarction or future lesions that may develop proximal to the insertion point of the bypass grafts. So my last slide is there is an alternative to CABG or PCI for left main stenosis, and that's hybrid therapy. I showed one of these cases early on today. I think this is a great technique, especially for isolated distal left main bifurcation or trifurcation left main disease. And I think that this is where we should be heading for many of these cases. Thank you all for your attention, and thanks as always to Greg for a great presentation and his ongoing friendship.
Great.